Today is Thursday, January 17th, 2019. This is Hannah Crawford for the Global Polio Eradication Initiative History Project. I'm in the CDC broadcast studios with Dr. Brent Burkholder, and we have had one pre-interview session and prep for today. Dr. Burkholder came to CDC in 1991 as an EIS officer. He's worked in polio eradication as a regional health advisor and program coordinator in the Southeast Asia region of the World Health Organization, and as director of GID at CDC, and now as an independent consultant on global health. So today we'll touch on years from 1991 all the way to today in 2019. Okay. And thank you for being here.
My pleasure.
So before we really kick it off, do I have your permission to ask you questions and record this interview?
Sure.
Great. So now we'll open it up, and in oral history we start with some biographical information. So would you mind stating your name, where and when you were born, and talking a little bit about your early life, where you come from?
Okay. I'm Brent Burkholder. I was born in Parkersburg, West Virginia. But I moved to Japan when I was 6 months old, and then to Korea when I was about a year and a half old, and grew up there till I was 18. So my parents were missionaries there, so I kind of started out with a real desire to work globally and appreciate different cultures and understand kind of how critical it is to appreciate how diverse we all are. And I think that kind of really helped drive a lot of my interests as I've kind of grown older as well. I ended up going on to college, and then eventually I joined the Peace Corps. I actually went back to Korea. I worked in the public health center up in the mountains of Korea and decided to go into medicine from that kind of experience. And after that, did residency and ended up at CDC.
From the periods that you just talked about, could you pull a couple of specific memories that maybe later shaped your work, or just that stand out for you as formative experiences?
Well, I think particularly Peace Corps experience kind of really helped drive my interest in public health and to work internationally for the long term professionally. I was a TB worker in a small rural public health center, and was in charge of, actually, I didn't have a lot of technical background with that. I have just a lot of interest. I had actually done some public health degree before that. So it kind of did it backwards than a lot of people do. But I realized quickly from that experience that kind of what you learn in school, and it's great to have that kind of theoretical knowledge, but really kind of understanding kind of what drives people's health and what drives their kind of important decisions in life is not all, you can't really grasp that from being in school, frankly. And so that looking at trying to really motivate people to get tested for TB, to take TB drugs if they happen to unfortunately be positive, and trying to really understand what their individual priorities were. I think that really what helped kind of drive me to kind of look in terms of how people just get by on a day-to-day basis in kind of a lot of different challenges that they have, and recognizing how vibrant public health can be for someone's life and make a real difference. But at the same time, that the role for public health and everyone involved can be at very different levels. I think that I found that I was driven to kind of having a more deeper kind of understanding of what some of the kind of clinical aspects were of what I was dealing with, which kind of pushed me to medicine, but also appreciating that you really need to grasp kind of what's happening at the local level to be able to really appreciate it at the kind of national level or higher up, kind of what really needs to happen to make a program or to make anybody motivated and to make it really effective and work. So,
Can you talk, you said that you were at a rural health center in Korea. Could you talk about some of the people you met who came for care?
yeah, it was really, this was back in the early 80s. So today, I don't know if, I think a lot of people have maybe even been to South Korea or know about Korea now being a very, very developed country and very high technological capacity. But back then, Korea was still basically a developing country. And in that era, it was mostly a farming community. So most of the people who we were serving in that area, it was really up in the DMZ, the demilitarized zone, really near North Korea. And most of the people were quite poor. And a lot of the younger people were tending to leave. So a lot of our population tended to be older. So it was a real difficulty for them to come out to the health center. So we spent a lot of time with my coworker going around village to village and house to house even. It sounds like polio, doesn't it? Kind of trying to get people to be tested for in that case, for tuberculosis and to track patients and trying to particularly to get them to follow up. And most of our patients had to take the drugs for a couple of years at that time. And so you got to know a lot of the patients quite well in terms of going to visit them almost on a monthly or at least every couple of months basis. So that really was very rewarding.
That's great. And I wonder also about any early memories you have of Korea as a little person?
As a little person? Well, I grew up in Seoul, and it was so this was in the 50s, mid 50s. So it was right after really right after the Korean War, and so it was again still pretty basic in terms of the standard of living, and even our houses were pretty basic. But there were a lot of ravages of war around there, a lot of buildings that were still destroyed. And I remember the one time my mom said she aged about 50 years is our house was built on a hill not too far. There, a lot of fighting had taken place in Seoul during the war. And so some friends and I were playing basketball outside, and I ran up this hill, and something rolled down off the hill. And because I'd slipped going down, and I looked down there, and it was a hand grenade, and still a live hand grenade. And so since I was the one who found it, I got to pick it up. And I went down, my neighbor kids, and other missionary kids, their older brother he was really big into military things. And so I ran down the hill with him, holding this with my friends down to show him what we found. And so he came out and very gingerly picked it up and kind of placed it in a culvert. And they called the bomb squad to come and everything. But my mom said that I had been blessed with good hands or something, that had been an angel had been on my shoulder to guide me for that time period. But so I managed to survive that. I think I was about 5 or 6 when that happened. And so after that, it was easy.
You said that you kind of went from public health to medicine, and then that's an unusual progression. In a way, usually people become doctors and then find their way into public health. Could you talk a little more about how that happened and how you made that decision? Was there a moment, or, I mean, you talked a bit already about the progression, but I just wondered if there was a moment.
Yeah, I wouldn't say there was a specific moment. My grandfather on my mother's side was a rural doctor in way up in Kentucky in the hills, and so I had I'd never actually met him. Unfortunately, he died before I was born. But my mom had told me a lot of stories about, his service and working in his community, and so at least I had that kind of inkling of things in terms of what medicine could do. And my parents my father was a minister, my mom was a teacher, so they were very service oriented. But I think one of the other key aspects was seeing there were a couple of medical missionaries. One was a nurse and one was a doctor who I really admired. And quite frankly, I saw them as being having much more effective kind of impact than my parents even, because my parents obviously were working either in education or in ministry, which I totally appreciate much more now as being very relevant to people's lives. But I could see the health workers having much more direct kind of impact and appreciation from people about the benefits that they were able to bring. And in particular, one nurse who I actually got to know, a good friend of my parents, and went to visit her a couple of times. And she was actually working in TB, turns out near the area where I ended up working later. But I think that kind of drove me into doing public health work initially. And it kind of serendipitously, ended up back in Korea. That was just kind of the way that the Peace Corps rotations of what was available then. But I think that kind of reinforced my appreciation of what public health could do in people's lives, as I talked a little bit about before. But I kind of found that I really wanted to have a better understanding of why we were advocating for certain either public health policies or certain drugs, or why this worked or not. And so kind of wanting to have a better kind of clinical understanding, and being able to also see people who came into the health facility who really needed more direct care beyond what we were able to do for the general population. And in some ways, there's a lot more direct reward individually from having a direct patient contact. And so frankly, that was part of the drive, because initially I felt I wanted to go to med school and return back to work probably in Asia, in some rural areas as with an NGO or missionary doctor, and do clinical medicine along with public health. So that was kind of my initial thoughts.
So how did you come to work in polio eradication?
Well, I blame Bob Keegan and Steve Kochi. So two names I'm sure you've run across before already, who they're really kind of the real kind of pioneers of polio eradication globally, but also specifically here at CDC. I mean, they were the two people who started the program, and really dynamic people, and very visionary, and very driven and motivated. And I was working after I was in EIS. I joined and worked in the emergency and refugee health group for about 10 years. And then one day Steve and Bob approached me and asked me if I'd like to join in terms of the polio department and work in Southeast Asia. And that was a good time for me to kind of shift gears a little bit. I was tired of doing just emergency work that was very kind of episodic, and looking for a longer term, bigger program to work in. And so they offered me this opportunity to move to Delhi, and they were very persuasive. And here I am, 20 years later.
And was that in 2000 that you moved?
I moved in 2000, right.
Okay. So that's the first target date for the end of polio. Do you remember, what did you know about the polio eradication program when you first started working as part of it?
Not a lot. I'd had some tangential kind of contact when I was doing the emergency work, because I was working in a number of areas that I worked in Somalia and Bosnia and Kosovo and Zaire and a number of other places that were still having polio campaigns even in the late 90s. And I remember particularly there was Operation Mekakar that was working in that area of the Balkans when I was working there. And so we had some contact with that group at that point. But I didn't know much other than, as Steve and Bob told me, is, obviously the initial idea was that we were going to be done in 2000, and that wasn't quite there. But everybody was looking to 2005, and that was the next kind of real goal, and that they were really focusing on India and Southeast Asia as being real priorities to address eradication and get there finally.
And what did you know about working in the Southeast Asian region of the WHO?
Very little, actually. I mean, I traveled around there a little bit when I was in Peace Corps, but really didn't know much at all about that, and really hadn't had that much contact with WHO because they were not that directly involved in emergencies. So I was kind of showing up there pretty uninitiated, frankly, and even frankly didn't have a whole lot of technical background in polio, and I really am thankful to Bob and Steve and others who were willing to kind of help me learn and to accept me for where I was and to hopefully see that I had potential to kind of help provide some support to the program. So.
And how did you become initiated? What were your first 6 months like?
Wow, it's kind of a fire hose of landing in Delhi, which is moving from Atlanta to Delhi. So part of it is just the kind of the personal transitions to a new country and culture. And in some ways, like I said, growing up, my background and even the work experience at CDC and emergencies, I was used to kind of being in different countries and cultures. But it had been quite a while since I'd actually lived in another country, which is quite a different experience when you have to deal with it on a day-to-day basis. So part of it was adapting to a new country and culture of a huge city of, I don't know how many millions it was then. It's probably 18, 19 million now, but it's just kind of overwhelming. But also the culture of WHO. And so regional office for 11 countries in Southeast Asia. And I think there were 5 countries then that still had polio going on, in addition to India. But India was obviously the largest source of cases then. But we were also responsible for all immunization in terms of the technical aspects. But WHO is it's a strange organization. I think I've heard the difference in terms of CDC and WHO. You've probably heard this before. I don't know if Bill Foege said it or who said it originally, but CDC is a technical organization that occasionally has to deal with political things, and WHO is a political organization which occasionally has to deal with technical things. So I think that's obviously an oversimplification, and they've, I think, come a long way. But WHO, particularly back 20 years ago, I think tried to just be very normative. That is, they were kind of focused on providing guidelines and sitting in their offices and really kind of just providing advice from afar and really not getting engaged at all in implementation. So that's one thing that I think that polio was really the first era, the first kind of foray that WHO has had in terms of really being engaged. And I think India, frankly, is probably the area where they really expanded the most. And there were a lot of people who were really reticent to do that, and particularly even our some of the leadership in WHO in the regional office. and it was only through the kind of the force of some of the directives from Geneva that kind of pushed them to kind of allow this. But they were, frankly, kind of lukewarm at best in terms of getting it started. And John Andrus, who hopefully you've also talked to or will, he was the first person who really got this initiated in India from CDC. And he was the first regional advisor who really started the polio program in the late 90s, mid to late 90s, and started a major program in the India country office as well. And it was a still fairly small program when I started. I think they had they had about 40 or maybe 50 staff already then. But that's kind of the impetus of it, and where it kind of, and they had just beginning to have a WHO presence in some of the other countries like Nepal and Bangladesh and Indonesia, but it was very, very small. And I think that was the time when Bruce Alward was head of the polio program at WHO. And he was really very charismatic, very dynamic, and very visionary in terms of kind of what needed to happen, particularly if we were going to reach the goal of eradication by 2005. I can't remember the exact number in the cases in the world we had in 2000 when I started, but it was in the thousands. And India had about 1,000 cases, I think, the year before when I came. So it was clear, and I think Bruce was really a really forerunner in terms of seeing where WHO could have an impact. And one of the key things that we tried to do there was to really push the expansion of what became the NPSP, the National Polio Surveillance Project. It already started, as I mentioned, under John. But in the next few years, we really expanded it from, as I said, about 50 to, I think, ended up over 900, 1,000 SMOs, or surveillance medical officers, throughout the country over the next 4 to 5 years, and also expanded the same SMO kind of concept in multiple countries throughout the region. And I think, looking back, I'm sure others would hope agree as well, that I think the NPSP and that whole kind of organizational kind of construct was what was really critical and instrumental in achieving eradication in Southeast Asia.
You mentioned Reticence at the beginning of the program. Do you recall any of the general reasons for the Reticence, or what your impressions were for that existing?
Yeah, I don't think it's too pejorative to say. I mean, looking back, I guess we can say this is like when I remember the first day I walked in. I went as a preliminary visit with John to visit Delhi. Before I joined up, I went into kind of in early 2000 to kind of meet people and kind of mutually and see whether this was going to be a good fit for me to go there. And I remember walking into the meeting of all the top leadership of WHO CRO. And frankly, I thought I'd walked into an old folks' home. The average age was at least 70, and the regional director was in his late 70s, I think, and there was really not a lot of dynamism. There was not a lot of kind of interest in rocking the boat or doing anything innovative or doing more than what I think was generally perceived in terms of WHO's role of writing technical documents. So I think there was just, again, I don't know how prevalent this was throughout other WHO regions, I think, were very different. Because obviously, in the Americas, in PAHO, which is the element of they joined WHO. They started even before WHO, but PAHO was really dynamic here, and they were the ones who really brokered the polio program in the Americas and made it happen. So I don't think this was necessarily kind of inherent in WHO per se, but I think at least in that office it was very kind of provincial, at least in my thoughts of how it was. In terms of, or provincial may not be the right words, at least it was very kind of prescribed, traditional, probably a better word for it. They were very traditional in terms of what they felt they should do, and that UNICEF or NGOs or governments should be kind of the real players and real actors, and particularly the governments, that they felt that the government should be the people who carry out and implement public health programs, and not UN agencies. And I really understand that, and I think that that's, in some ways, that's that should be a core principle, is that the government should have the responsibility for providing services to their people. And maybe we'll get into this further, but as well, I think the whole issues that have dogged the polio program in many ways is in terms of kind of superseding the system, and that polio kind of basically held back development of routine or essential immunization, and basically took over that role, and so that the government just withdrew and held back from really kind of taking on that obligation or accountability. And I think that's a legitimate concern, and I think that's something that the polio program, both now and historically, is going to have to answer and be able to really kind of appreciate. And maybe hopefully that's part of the history project, is understanding how that transition has happened and how we're going to take this forward. I know this is still, last chapters are not written yet, but I am hopeful and confident that when final chapters are written, that it'll be a positive. But thinking back from in the early 2000s when I was first starting and seeing how that kind of different perspectives in terms of the role of different agencies and the role of government per se, I think it was still not clear, but I think it was, or I should say that at least that if we were going to succeed by 2005 at that stage, that we could not, we being the global community, and even many of those in India, there were some very strong supporters of polio in India. I should mention to start with, particularly Rotary, recognized that the government did not have the capacity or interest to do that on their own, and that others, particularly at that stage, it was WHO, UNICEF, Rotary, and CDC, who were most engaged and were going to have to really play a much more active role, because the government just didn't have the people or the resources or the interest to do it. So,
as you were in that room and just entering into India, what did it mean for you and the way that you thought about your role, to hear the government's perspective on UN, the role of UN agencies and their role in immunization programs?
Well, actually, when I was speaking of that room, was actually within WHO.
Oh, thank you.
So it wasn't the government side. This was within WHO in the regional office, really. That this was a very kind of staid, traditional way. At that stage, initially the government, partly through the, I think to a large extent through the push of Rotary, had already started, and John had really been instrumental in ensuring that the first SIAs, the first supplemental immunization activities nationwide, took place. So those had already happened, so the government had really at least approved this, even though most of the funding and a lot of the initiative had come from UN organizations already, particularly WHO and UNICEF, which were, as I said, just getting started, but still had a nidus of some key epidemiologists and staff to get it going. But I think that the real change in the India program happened when the government took over responsibility. And I think this was a kind of a gradual process, but it kind of, I think, was primarily dependent on a couple of key individuals, and recognizing the real importance that some individuals can have, even if it's a huge program or even if there's a lot of other external forces. But Dr. Soban Sarkar, who was head of the immunization program for India, he's really a dynamic character, and I hope you get to talk to him as part of this as well. But he was always just a little bit crazy, but super energetic, and kind of he would call me up in the middle of the night saying about issues or problems they had with an SIA in this town or this district, and he didn't know what he was going to do. But he was always engaged, and he and one of the secretaries of health, Secretary Hota, were really determined that the government of India should take on the funding and therefore the responsibilities for the program. And this was a couple $100 million a year. It was not a small amount. Although India is a big country and a big budget, but their health budget and percentages were not that high. And it's also, it's a federal system, and even more than in the U.S., the states have responsibility for health. So taking on a national goal such as polio eradication was a major step. And I think that once they got through by, I think, just force of personality, and they actually, obviously, I keep mentioning back in terms of the contributions that Rotary had to have access to the highest levels of government, including the Prime Minister, Vajpayee, at that time. And they were able to get the government to agree that polio should be a budget line, which is a very major, significant kind of standardization of the process, so that it continued as they have done in the U.S., which has been very critical for the CDC, but also in India in terms of getting the budget line and getting the government to commit substantial amounts of funding long term. And that kind of the political will in that process kind of then cascaded down to the states and further down to the districts. And I think that was really what was the key kind of turning point in India. I mean, the cases still continued to go, and we even had a couple of years in, we dropped the cases down. I remember we were dropping from 900 to 500 to 200s, and we thought we were definitely coming down. And then I think it's 2003 or 4, they jumped up to 1,600. And we were really, really crestfallen at that stage. That felt that we were headed obviously in the wrong direction. But eventually, obviously, it turned the other way, and last case was 2011. It took longer than we thought, but I still think that the key turning point was back in 2003 or 4, I'm not exactly sure which date, the government agreed to take on responsibility. And then that really helped drive it. And so I think that kind of goes back a little bit about kind of thinking about kind of what's the role for GPEI or UN organizations or CDC vis-a-vis the governments. And kind of that's why I said I don't think it's really a black and white situation about how a vertical program kind of functions and the system component, and how the role of global or or bigger international organizations compared to government responsibilities. I think it really has to be a close match, and I think it's a bit of give and take. But that's certainly kind of evolved over time, and it's not always evident at the time.
Do you remember how the culture of WHO and NPSP maybe changed after that turning point?
Yeah, I think it was kind of coincident with a couple of things happening at the same time. One is Jay Winger came in as director for NPSP right about this time, and he had some really dynamic surveillance medical officers, Indian officers, who were really, really sharp. And I think that as I mentioned, we'd kind of already started, even before Jay came, we'd started to expand the number of SMOs. And I think that the government's kind of buy-in to that really helped to solidify kind of the role of the SMOs, and that as the chief ministers in each state kind of took on the kind of responsibility and accountability for eradicating polio, they looked around to see what resources they had, and I think particularly those who were very perceptive obviously realized, well, the SMOs and WHO and UNICEF, who had started also kind of concomitantly starting a communications network of people at the local level to help push the polio program, that they were their best resource to be able to meet what was for them also a very positive political goal, to be able to show that they'd eradicated polio. So I think it was kind of I was thinking particularly there were a number of times going into to see a lot of part of my role. Jay was actually doing a lot of the work in terms of a lot of the technical issues and driving the kind of management of a huge program and ensuring that we had the right vaccine and all of the operationals. And part of the role I was playing was trying to be much more in terms of some of the political advocacy components. So part of my role was going to meet with the chief ministers of the key states. We had about 4 or 5 key states, UP and Bihar, West Bengal, Maharashtra. The southern states had a much better capacity and historically, and were able to do much more on their own. But particularly in the northern and central states, they'd traditionally been much poorer. They had a higher percentage of Muslims, so that there was a lot of disenfranchised populations, and a lot of tribal populations, a lot of migrant populations. Often kind of my role was then going in with it, usually almost always with a Rotarian. I remember going with Raja Cebu. I mean, you've talked with him, but I remember going with him to the chief minister of Haryana, one of the key states in the north, and they were old friends. And most or many of the chief ministers were Rotarians, and it just amazed me how pervasive their influence was, regardless of which political party was in control. Some Rotarian knew the minister, knew the prime minister. They always knew people, and they would always be able to get us access. And so I think that was also critical in being able to kind of drive the program forward.
Could you talk about what it was like to go with Raja Cebu? How does this actually happen? I know the Rotarians definitely know people.
Yeah.
But could you kind of illustrate what it's like to actually meet with people, ministers of health?
Well, yeah, it was at different levels. Obviously, there was the ministers of health, but also and frankly, the Minister of Health was probably not as powerful as the chief ministers in the states. I mean, we met with the Secretary of Health or the Minister. The Secretary of Health in Delhi, we'd meet with, particularly depending on the minister, but with Secretary Hota, we met with almost every week, and all in just in his office. And that's kind of, the representatives from all the different UN agencies and Dr. Sakar, and that's, it's thinking of like, we're meeting with the Dr. Price or Dr. Azir, with the Secretary or Minister of Health. We didn't meet the minister every week, but we met the minister probably every couple of months, but certainly the secretary was the next kind of key administrative officer every week. But the key, and because they were very engaged, but as I said, I think at the state level, these were the people, and this is like meeting the governor, and getting into the governor, and often the governors are God in these states, and they usually have very palatial, the old British Raj kind of houses, that big white building with columns, and they live there, but it's also their office. And I'm thinking particularly the one thinking now in Lucknow, which is the capital in Uttar Pradesh, and it's in some ways very opulent, but it's also chaotic because there's all kinds of supplicants who are coming in wanting to have meetings, and it's a very like many things in India, it's all chaotic, but there's a system kind of flowing underneath that you may not all, and certainly as an outsider, I didn't understand. And I learned a little bit of Hindi, but not enough to converse. But I mean, all the educated people in India speak English because it's actually a much more universal language than even Hindi. So we would drive up usually with a small entourage of someone from Rotary and a WHO person, and you'd go into this big outside room, and there's still like dozens of people like milling around, and then you always had to wait around a little bit, but then often you'd go in to this room and they'd say, come on in. Somebody would finally let you in, and then the governor would be there, the chief minister would be up at his desk talking to people like in some chairs in front of him, and then there's people coming and going all the time, and you'd sit on the side. It's kind of, I don't know what to relate it to, but there would be all kinds of conversations going on at the same time. And then so the governor would meet people, and then, or the chief minister, and then the people, whoever he was most talking to, then would get up and walk out, and then you'd be ushered to come sit in these chairs in front of him. And always you'd have tea, always had to have tea. But then the Rotarian was the one who usually really pushed the agenda, at least starting it off, and recognizing, kind of why we were there and what the importance was. And many times, often Bruce would come with me from headquarters, and he was a master at being able to relate to what people's issues were and how to make them look good, and how we could help him look good by achieving polio eradication. And then usually trying to come up with some specific ask in terms of support for an upcoming SIA or something like that. But it was always, usually the meetings were fairly short, maybe 10, 15 minutes. And sometimes you would have traveled, even flying for, a couple hours and waiting, and, take hours and hours of preparation, but you got in for about 15 minutes of FaceTime with the chief minister. But that was critical, because then the chief minister, he always had some scribe sitting over there who would take notes and say, okay, then this had to be done. And in that case, it got done. in that not only at the state level, but particularly down to the district level. And I think that's what was key in India, was getting the district magistrates involved, because they are the ones who really, these are just anywhere from, I don't know, 250 to 500,000 or more people in a district. So, but these people really have the say about what happens in that area. And if the chief minister and the key district magistrates agreed that this needed to happen, it would happen. So they're very, very powerful. And I think that's to real credit of the Indians, is they're very resourceful, and it's a kind of a slow-moving machine. But once it kind of got the momentum going and kind of got the initiative with it, I mean, it did take a few years, obviously, till 2011, but it happened. And just trying to think of, the millions and millions of people that it took, and the effort in terms of the number of SIAs and outreach to do that, I think is just a tremendous testimony to the Indian people.
What would you say some of the lessons learned are from your perspective, from your time in India?
Well, I think a couple of things I've already kind of alluded to. I would say, one, it's not over till it's over. And that, as I said, we thought we were on the right track, and then we had some setbacks in hindsight, perhaps of things we technically did wrong, but I think also I think it was just a whole kind of lot of issues that kind of came up that we weren't able to get ahead of the virus. So it's not over till it's over. Even though you think it's kind of getting better, you always have to be vigilant and know that you're not going to achieve eradication until you've assured that you have at least 3 years without any cases. And we saw that in a number of other countries in that region. I mean, Indonesia, I know, went, I think, 4 years without a case, and then we had an importation that came over from Yemen, and we had 400 cases, I think. So I think that's one thing, is you really cannot be complacent and recognize that it really takes a lot of perseverance, and that it's not done until you really are satisfied that you've stopped transmission. I think another lesson, again, as I was alluding to with Dr. Sakhar and Dr. Hota, is even though it takes a huge army of people to accomplish a public health goal, that certain key individuals and their impact can really be tremendous, and really can have a really ripple effect that may not even be evident to themselves, and we may not know until after the fact. And I think the other is, and I think perhaps related to those as well, is that certainly we need the technical understandings, and I think the issues about understanding surveillance, I think that was another tremendous kind of impact of, and that's what NPSP and WHO and CDC brought, was kind of the mindset of epidemiology and how that can help drive decision making. I think that was a really critical element to the program that really it was also absolutely critical in terms of being able to target resources and understand the epidemiology. That obviously is a critical piece, but I think also recognizing that appreciating the political element and the community element were also instrumental. I think that as we're still seeing today, I mean, the problems that we have in Pakistan and we've had in Nigeria and Afghanistan in terms of some of the resistance and refusals for vaccination. We had some of that in India. Certainly, I think it is not like that everybody was clamoring for the vaccine. And UNICEF, and particularly Mike Galway, and I don't know if you had a chance to talk with him about it, but he really turned around the communication network that UNICEF started.
SMNet?
SMNet, yeah, and really kind of transformed that into kind of in many ways it was data driven in terms of understanding focus groups and then how to generate kind of community engagement and really not only to address concerns that people had or refusals, but also motivating people to be engaged. So recognizing that it takes so many different aspects for a public health program to succeed, and that sometimes you can get in your own lane and think, okay, well, it's like, well, we need, the technical, we need the lab or the surveillance, and that's going to do it. And obviously that's not enough. And neither is the political piece. You can't do that by itself and expect the program to succeed. But that you, I think, most critically have to get the communities engaged and understand, understanding their priorities and what their concerns are. And as I kind of circling back a little bit to some of what I felt I kind of gained from the Peace Corps experience was that kind of appreciation of knowing where public health fits into people's daily lives. I think that was really instrumental in India in terms of that appreciation of that.
What's the answer to that for you? Where did public health fit into the lives of people in India from what you observed?
I think in India is, it's hard to I'm not sure who said it, it's something about, everything you say about India is right, anything you say about India is wrong, because it's so diverse that, and so many different kind of milieus and cultures and castes and things, it's hard to really make generalizations. That being said, I'll probably try and generalize that I think it's obviously gradually changing, but I mean the key kind of drivers of health issues are communicable diseases and issues revolving around sanitation and or lack thereof and clean water. And I think there's been a real appreciation in the certainly in government levels and others that in terms of health can help to generate economic growth as well. So there's been that kind of support for it from that perspective. But I think to more of the heart of your question in terms of at the local level, and I'm particularly looking at the moms and recognize, I think mothers the world over recognize, that they want what's best for their kids. And I think that they clearly recognize that poor water and sanitation is not amenable to good livelihood for kids, and that if they can't get good water and clean water, and the kids are going to continue to have diarrhea or won't grow. They can't get sufficient food. So I think that there is. Even though I think I'm, I've chosen to go into the field of medicine and public health, I've still always felt that the biggest contributor to improving global health is women's education. And I think that I'm sure I know there are a number of studies which have done looking at this, but I think it's just intuitive that ensuring literacy among women who are primarily the caregivers in most cultures, that their understanding intuitively knowing that they want what's best for their kids, that if they have the capacity and the literacy to be able to know how to kind of take that forward and implement that, you can create demand on a system for services. You can create behaviors that will be amenable for that. And so I think that I don't think it's necessarily hard to sell public health. It's just kind of ensuring that people have the capacity and the wherewithal to be able to implement it.
Thinking about systems, like having systems approaches.
Yep.
And I'm also remembering some of the interviews that I've done with people who have worked with UNICEF in particular. Michael Galway is one, Shireen Gergis is another, who talked about, and actually Michael Galway and I talked mostly about Nigeria in that interview, but I was wondering if you could talk about UNICEF's contributions and SMNet and your own exposure to that and social data becoming more important or more acknowledged, really. I think it's always been important. But
Yeah, I can't speak as much to the Nigeria situation. I've been in, when I was working here at GID, I went several times to Nigeria, but more tangentially for visits. But I know certainly much more firsthand in terms of UNICEF's role in India and Southeast Asia. But also, I think it was clear that Michael and others play a key role in Nigeria. Had some of the real challenges addressing political kind of manipulations that we're facing now in Pakistan and Afghanistan in terms of how the Taliban and others have utilized some of the misconceptions or their own kind of interpretations of some of the initiatives and how they've used that to their advantage. That's a little off track, but recognizing that, as I said, I think trying to understand where the communities are coming from and what their priorities are and how public health affects their lives, as I mentioned, I think is a critical component of public health program success. And I think that's even doubly so when you're having to deal with people who are, frankly, I think for their own political reasons, trying to circumvent or try to take advantage of disinformation to be able to put the polio program or any public health program off track. So that even creates an added burden of that, and it really even underscores further the importance of kind of social communication, social mobilization. So I think I'd have to say, quite frankly, I kind of went into the polio program starting out with a fairly naive or jaundiced view of what UNICEF's role was in communication, and perhaps a fairly, I hate to say too pejoratively, but a medical approach to it in terms of thinking, okay, well, that's kind of, the docs and the public health, we'll take care of this. This is the real public health, and kind of that's advertising over there, and that's kind of like touchy-feely stuff is not so critical. So I think that was my initial impression, quite frankly, and I think I was quickly kind of dissuaded by that, by recognizing that we had a long way to go in terms of being able to convince communities that, because we still had a fair amount of refusals and we didn't have the communities engaged in a lot of the program SIAs that we were trying to conduct. Recognizing, though, that UNICEF played a role, but that I wasn't sure how. I thought it was more tangential. It wasn't an integral role, frankly. But I think, as I say, two people I think at UNICEF. One was Michael, and then also the country director there, Maria Calaveras. She was extremely visionary and I think was very courageous in terms of pushing UNICEF's role. we were not clear who was going to take responsibility for social mobilization and that aspect. And actually, when I first came, WHO actually had a social mobilization person on our staff, and UNICEF was really they really did not have a leadership role. And I think Maria then, and I'm not sure exactly where it came from on her own, I think, but she really recognized UNICEF needed to step up. They were always engaged in terms of vaccine procurement, but had not had a clear leadership role in the social mobilization piece component of it until she kind of put that forward and took on that responsibility. And I remember one NID in particular where at that time, this was before the government had agreed to fund a lot of the things themselves, but we were really kind of living hand to mouth for a lot of the SIAs and having enough funding to buy the vaccine. And I knew we had a very tight time frame for SIAs because we had to set a date in advance for the national program. And you're immunizing about, let's see, there's a birth cohort of 25 million. So we were doing like 250 million kids in a couple of days in the country. So it's a massive operation. And so you have to set those months in advance, and you have to also obviously order the vaccine prior to that in order to get there obviously exactly on time. And we were coming down to a deadline of just a couple of days to order the vaccine, and we didn't have the money. And Maria was willing to put up UNICEF's other funds from other programs as collateral and basically use that for the vaccine on the hope that these other loans and polio-specific money would come in to fill that gap. And I think to me it's a courageous step on her part, and we actually obviously got the vaccine, and we also got the money to backfill for those other programs. But I know that even at that level, there are people like Maria who really believed in the program and were willing to kind of take risks with that, and then to provide the support and the direction for people like Michael to come in, who really as I mentioned a little before, I think really took social mobilization to a whole new level in terms of a real data-driven scientific approach of using numerous kind of focal groups and other social data to be able to really kind of drive kind of the communication messaging and understanding kind of what was needed to make the program successful. And I think they then has generated a huge network at the local level that is even now being really utilized in multiple other public health programs. And I think I gained a whole new appreciation and hopefully much wiser understanding of kind of how public health programs have to work from that experience.
Was there a turning point for you where you moved from the, I think you said, medical kind of approach and perspective to something different?
I think I remember one meeting in particular in Moradabad, which is a major city in Uttar Pradesh, and in India, a major city is, you have to have at least 1 million, 2 million. So I mean, there's like. But it's a big city. It was a major area that we'd had a lot of cases, had a very high Muslim population, and so there'd been quite a bit of resistance. Again, not because the populations were Muslim, but because many of these areas they were being highly discriminated against, and a lot of the vaccination teams that were being organized were not from the community, and they were actually sending in, they were organizing Hindu teams to go into Muslim neighborhoods, and so it really just wasn't really progressing. And I remember going with Michael to a key meeting of the local polio teams in Moradabad with the SMOs, the surveillance medical officers there, the local government people, and just kind of it was when it was just beginning this social network people, and the way that Michael was able to, he really was engaged each of these local kind of different kind of segments, and was really drawing out from them kind of what the issues were, and kind of getting them to kind of come to their own conclusions about some of these issues and challenges that how you needed to engage the community. And he had a great capacity of being able to get them to identify what the issues were and how that they could be resolved and get addressed. And in terms of engaging the local imams and religious leaders, and basically trying to get much more community-based kind of volunteers, which now seems like as a standard in Pakistan, but was really driven very much by the experience in India before that. So I think that meeting in particular, which really stands out to me, where Michael was really able to organize it, and I saw his approach in terms of being able to get those engaged and get the local groups to be able to understand what the problems were and what the kind of the new approaches needed to be. I think that kind of helped really kind of say, okay, well, I know that he knows what he's doing, and so now we've got a chance. So.
Do you remember what he would say? Do you remember his approach? How did he do it?
God, I wish I had that good a memory. No, I don't really, frankly, other than I know that this was well before PowerPoints, and we didn't use PowerPoints or anything. It was all kind of flip charts and magic markers of things. And we did in some small group kind of discussions and things, but.
So he led the group.
Yeah, he led it, but it was as I said, he had a really innate capacity to be able to get others to kind of be self-reflective, and to get his groups to come up with their own kind of appreciation of what the issues were, and that's hard to do. And I think that's particularly. I mean, some cultures are easier to do it than others, and sometimes everybody likes to talk or nobody likes to talk, and so sometimes you have to kind of know how to make that happen. So.
Did you have any experiences that were related to security issues in India? I know that's generally more connected, maybe with the remaining endemic countries now, especially, but I just wondered if you had any experience with that.
We didn't have a whole lot in certainly not to the extent that you have in Afghanistan or even Pakistan or in Borno these days. There were some issues with bandits and tribal groups up in the Northeast, fairly low population groups. I think the component that we did have somewhat related to that was always issues of traffic accidents, and in terms of we had a couple of unfortunate situations where, because our SMOs had cars and had their drivers, and we had a couple of incidents where cars killed people, and in those circumstances, particularly in rural India, the first kind of initiative from villagers is to hold the driver responsible, regardless whether he or she is or not. In some cases, they were, but it could just be an unfortunate circumstance of a kid running out or something. But we had a couple of instances where fortunately, I don't think anyone was actually killed in retribution, but I know that there were a couple of circumstances where drivers and the SMOs were kind of held hostage by villagers because they had been involved in an accident and were held responsible until compensation was paid to the family. So certainly it's not to the extent that the programs are facing now in Afghanistan and Pakistan.
Very different, yeah.
Very different, but there's some of that element that they had to be concerned in terms of the safety of the SMOs, not to the extent for I mean, there were some times where as I said, where if in the early stages, some of the vaccinators were not from their communities, and so people would, be very angry to them and things. But I don't recall any vaccinators in India being killed, fortunately, from that standpoint.
So we're kind of continuing to talk about India and beginning to wind down from at least this part. But I wondered if there's anywhere you would like to begin. I'm interested in talking about the vaccine with you.
No, I think the only thing that I want to make sure to mention, I think, two things. One is I think the tremendous contribution of the volunteers and the vaccinators and the millions of volunteers who participated and when we did NIDs and who either without pay or very minimal pay in very very hot or very trying circumstances, that they think they deserve tremendous amount of acknowledgement for what they did. And secondly is the SMOs, the surveillance medical officers of NPSP, who I think were really the unsung heroes of kind of really the backbone of the whole program, and have, I think, maybe we'll talk about transition more, but I think they kind of the epitome of now are seeing kind of how they are helping to really take what was anticipated in terms of the surveillance medical system and really translate that into other components and utilize that for their programs. And without getting too off track on your questions, but I can remember in Bihar of going to a district medical facility, and it's a compound with a couple of buildings, and in the back I saw these old Jeeps that were all overgrown and they're all rusted out, and I went and looked on the side, and it was from the smallpox program, from when India was doing smallpox, and I think unfortunately, that's kind of was real emblematic of the legacy of smallpox, of kind of, it was great accomplishment, and certainly, other than rinderpest, the human eradication, disease being eradicated, but hasn't been really much except that kind of rusted out legacy of that. And I think that kind of thinking about what we need to do for polio and hopefully not only achieving eradication, but thinking kind of what are we going to leave behind. I think that the SMOs and kind of this whole cadre of people, not only in India, but I mean there were others, certainly in Nepal and Bangladesh and other areas that are really kind of key public health leaders, not only in India, but there are a lot of SMOs who are really key players in like Gates Foundation, WHO, UNICEF these days. They're in leadership positions globally as well as nationally. And I think that's a kind of a key point that hopefully will kind of come out in not only your project, but I think will be a key kind of acknowledgement of kind of governments and systems today. So I think that's I guess what I wanted to make sure got mentioned.
Yeah, for sure. Is there anything else you would want to say about smallpox? You know, because part of in bringing up the transition, you know, part of the idea of polio eradication is to leave a legacy of infrastructure and human resources, technology. What was useful in your own experience from smallpox?
Well, I think on a personal basis, I learned a lot from some of the people who've been engaged with smallpox eradication. I mean, Bill Foege obviously is probably one of the most well-known, and he came to India several times. But there were a couple of other people who worked directly in India, Graham Sales, Nick Ward, who were critical players in the smallpox era when they were young, and they were very important and had a lot of good experiences that were relevant for our polio program. And I'm particularly thinking about Graham, who really was he hated being in headquarters, hated being in Delhi, but loved being in the field, and that I think was a holdover from his smallpox experience when he was working in Bangladesh and India on that. And he was, I think, the one who really kind of helped me to appreciate kind of how the SMOs could be used and to expand the network. And he, I think, was critical in trying to really push the expansion and looking at a structure that would help to support the SMOs. And again, based in terms of some of that experience that they had from smallpox. Certainly smallpox is a very different disease, transmitted very differently, and different approaches could be used. But I think their kind of their drive, commitment, and kind of real kind of appreciation of how they had to, again, hate to keep coming back to it, but in terms of the community kind of approach of things, really were instrumental in being able to achieve success for them.
When you say structure that was needed for the SMOs, could you describe that?
Yeah, I mean, initially we had as I said, I think we had 40 or 50 SMOs scattered throughout the whole country. And I think at that time there were, because they keep changing the number of states and dividing them up and out, but I think there were about 30 states. And we had more or less one in each state and a few in the bigger cities. But it became evident that they were really going to have to take on a lot more. And so we started to put more SMOs, train more, and put more in some of the key states. And as we expanded, realizing that we couldn't do it all from Delhi in terms of both managing them just administratively, and they also mushroomed in terms of, they each ended up getting data people and support staff and a driver and an office. And so it also became an infrastructure in itself. So we ended up with having regions within the country and then sub-regional offices and looking at and I think Graham was instrumental in looking at how to organize kind of sub-regional offices where you had one SMO kind of overseeing anywhere from 5 to 10 other SMOs in other districts and providing, usually these were folks who were, had experience and were technically really savvy or knew administratively how to handle issues and challenges and help the others. And so they provided that kind of a hierarchy of support. And so we had, it turned out, when you have, I forget, I think it's over 3,000, 4,000 employees eventually, when you count all of the non-professional support staff as well. And then ended up with even more field volunteers and field volunteers, but there are thousands more of them. So, the number of workers, were in the thousands. So it had to have some kind of structure to be able to deal with that.
I'm interested in hearing more about the volunteers, because there's a range of volunteers, or there was a range of volunteers.
Yeah.
Could you talk about who they were and how they were different from each other?
Yeah, there was a whole set in both WHO and UNICEF had different and called different cadres of people volunteers, even though they may have been paid. And I'm not as familiar with those under the SMNet that UNICEF had. In WHO, in addition to the vaccinators, who in essence were volunteers, but usually were given a stipend for the days that they delivered the vaccine. There was another set of field volunteers that were usually, often they were young guys with, had a motorcycle, and they'd get hired for because in many of the states we ended up with SIAs almost every month, certainly every 2 months. So there were 6 to 9 or more SIAs per year. So that there was a lot of work that needed to be done in terms of collecting information or delivering vaccines, or just a lot of kind of work doing in terms of collecting data, things that it wasn't real technical, but it really needed to be done in kind of management. So there are a lot of groups that they got hired. Sometimes initially were hired for a couple of weeks ahead of the SIA to deliver banners or collect information here or there, and then they kind of got expanded out more because it took more time to prepare. We had to follow up afterwards, so they got hired for a month, and then they kind of got onto 10, 11-month contracts and things, and then there were other volunteers who again, quote, volunteers, who are people who are hired to transport stool samples. Again, usually some guys with a motorcycle, to want to get a few extra bucks. And they would be, the SMOs would, identify an AFP case and then have to collect stools from them. And, you sometimes have to go back to get, and so they would have these volunteers, on the motorcycle go to the house to collect the stool sample the next day or whatever and bring it back. So there's all kind of different levels of responsibility. And I think, again, maybe we'll get to this, but thinking about, when you first started thinking about an eradication program and what it was going to require, there was no appreciation of how it would mushroom and how it would need this level of engagement and number of staff to make everything function. When you're trying to vaccinate 250 million children in a couple of days, what that requires, and the mobilization of manpower and administration and making sure the vaccine gets to the right place, and the cold boxes are there and that they get picked up afterwards, and all the tally sheets are picked up and collected and collated, and then that information is passed on up to the provincial and then Delhi and then consolidated up to Geneva or Atlanta. So it quickly mushrooms into needing armies of people to be able to deliver this service.
When you say, quote, volunteers, what do you mean?
In that some of the people did it for nothing, but for the most part, people were paid, and minimal amounts, frankly. And I can't even remember now. I think it was, for the vaccinators, it might have been 50, 100 rupees a day, which is a dollar. I don't know what the exchange rate is now, but then minimal amounts, but it was something. So.
It also sounds like the amount of work that was required and that was asked of a single volunteer was probably more than what you might normally ask.
Yeah, and there's certainly. I mean, the people who are hired in the field as, quote, field volunteers. I think we may actually change the title to something else, but because they obviously were being asked to do a lot more, and we're being paid a bit more than just the vaccinators were, because it was really expected some day-to-day responsibilities. But certainly that created its own challenges in terms of dealing with personnel issues and people wanting to hire their brother or cousin or even for small jobs. I mean, a job's a job and additional money, and so it became, in many ways, to be a patronage system. and again, that was one of the kind of fears that I think that WHO, some of the staff I mentioned before, had about being engaged in implementation, is that WHO would get kind of bogged down in a lot of personnel and administrative kind of concerns and not the technical side of things. And that was a real challenge, and I think it continues to be in many places. And I think what evolved in many of these areas is that many of these field volunteers were kind of, quote, it was put under the responsibility of a third party, of a company that would hire people and take responsibility for all of the administrative, management, disciplinary, and other things, and promise to deliver, have 50 people who would do X, Y, or Z. And WHO just gave them a contract for that. So that absolved WHO from having to deal with a lot of personnel issues, but also in some ways less control over things. But I think it's probably was just an expediency that was required. So.
Are there any other additional layers that maybe were not anticipated in 1988? What else did India need to support polio eradication?
Well, one aspect I didn't mention, but I think is somewhat anticipated, but I mean, that was the whole lab system. So I think that development of polio labs throughout the country, and then eventually it kind of really started working on the environmental surveillance, which has really been much more expanded recently in Pakistan and Nigeria and elsewhere. But in India, it was starting out with the environmental surveillance started in 3 or 4 places, and never really expanded to the extent we have now in Pakistan. But the polio lab network, I think we had 11 labs in the country. And they were obviously critical to the whole surveillance program with that. And then I think, kind of jumping around in terms of the layers, but I think what were called the IEAG, the India Expert Advisory Group. So we ended up with other kind of technical people that were kind of driving the program from the Indian side, because India obviously has a tremendous cadre of professionals, and you mentioned Jacob John at one point. He was on the IEAG, and key pediatricians and others who were professionals in relevant fields that really became the kind of the technical kind of advisory group for India. And I think the other countries Bangladesh had something similar. Smaller countries didn't as much, but certainly in India, the IEAG was a very kind of efficient and very powerful kind of decision-making kind of level that was critical for the program. And I'm sure there are many, many other pieces that I'm forgetting now, but there were a lot.
One that I'm thinking of is the vaccine, because things changed so much with the vaccine based on what was learned in India. Could you talk about that a bit in your experience with vaccine?
Sure. I mean, obviously, you can't do the polio program without the vaccine. And the key workhorse was the TOPV that we started with, it was always a bit of a challenge in terms of kind of looking at because they're Indian manufacturers and then they're global manufacturers, and with as WHO, I mean, we were kind of committed to only using manufacturers who are what are called pre-qualified. That is, the WHO has kind of examined their procedures and examined the quality of their product and recognizing that it's has standards and meets safety and potency criteria. And it was always a kind of a push and pull piece because, as I mentioned, India took over a lot of the funding, and they, I think, perhaps obviously wanted to use that money to support Indian manufacturers with the vaccine, and frankly, some of the Indian manufacturers, there were several that were quite good and became pre-qualified, but there were others that didn't quite meet that mark and that had some real kind of difficulties in maintaining standards, and WHO did not want to use these vaccines in the SIAs. So sometimes we had some disagreements with the government over kind of which vaccines would be used for the SIAs. We ended up with the Indians government did end up buying the vaccine from these manufacturers, but used that for the routine immunization or the essential immunization EPI program. And we would use the pre-qualified vaccines, even if it meant importing vaccines from other manufacturers from other countries for the SIAs. Who knows if that was the right approach, but we did have a situation where it was a case of MEF1, which was I forget what year it was, 2003 or 4, where some vials of contaminated vaccine got out and actually caused some paralysis of type 2, which we knew was not wild at that stage. It was caused by a contaminant to the vaccine. And I think we had like 7 or 8 cases of paralysis from that, and it was a huge challenge of dealing with that, tracking it down, trying to find out. And we never did exactly find out whether it was some kind of incompetence and quality control error, or if, God forbid, it was done on purpose. So in any case, it really underscored, though, the importance of the vaccine kind of quality, and because there was a lot of negative publicity surrounding that, as you can imagine, and having to kind of address that. I think in India there was a very small but very vocal anti-vaccine group. We've got that in the U.S. as well, but there was a group that was particularly vocal and organized demonstrations and write in the papers and could create a lot of havoc in terms of negative publicity, usually again surrounding the vaccine, not only in these cases like that I mentioned with the contaminated, but as unfortunately can often happen, is a child can die after receiving the vaccine, not related at all to the vaccine, but because children under 1 die from, unfortunately, a lot of other things that can happen at that age. And infant mortality is still, although it's much improved in India, was still fairly high. But they would seize on that and say, okay, this kid had polio vaccine at 9 a.m. and he died at 6 p.m. So they would utilize this as kind of a very kind of example of why the vaccine shouldn't be used, and that this, again, was as we're hearing now as well, this is all a imperialist plot, and, that mothers shouldn't trust WHO or others with this. So this was a kind of a, unfortunately, common occurrence that we had to deal with as well. So that was one aspect of the vaccine that was really kind of front and center almost all the time. I think there's a huge infrastructure and amazingly efficient in terms of transporting the vaccine and making sure that it reached all these different levels, all the way down to the smallest village in time for a big campaign. So there was that aspect of the whole kind of cold chain and infrastructure required from that. But the other kind of key point to vaccine, for getting off that, is recognizing that when we were looking at trying to consider technical innovations, there was, and I think Bruce and others were critically in terms of looking at this kind of scientifically, of looking at could we use the monovalent vaccine, and was pushing studies that were done that showed that the monovalent vaccines for types 1 and 3, which is what we were dealing with then, had higher efficacy than the TOPV. So we ended up making a decision to switch to the MOPV1 and MOPV3, in which both types 1 and 3 were ongoing simultaneously in different parts of the country, and sometimes some states had both going on at the same time. And we struggled a little bit with sometimes using one vaccine and would tamp down type 1, and then type 3 would come up, and then we used MOPV3 and that would come down, and then type 1 would come up. And so obviously eventually we've ended up with BOPV. So it's been kind of a progression. I think India was at the forefront of looking at different ways that the vaccines could be used and what was the most effective as we go forward. And now, obviously, we're looking at hopefully type 3 is gone, and whether we need to stay with BOPV or switch on to MOPV1 after we've already done the switch from TOPV. So.
You left as regional advisor in 2005, right? Was that before or after? Was that at the end of 2005?
December of 2005. Yeah.
So that's right at the second target date.
Yep.
What was the response what was your response, and what responses did you hear around you when that target came
and went? Yeah, I think there was. I can't remember how many countries we still had at 2005. I can look back. I mean, we still had. I had looked up at one point. I think 600 or 700 cases globally. But I think the number of countries. I think even at 2005, if I'm not mistaken, we were still down to 4 endemic countries, to India, Afghanistan, Pakistan, and Nigeria as endemic. There were certainly countries that got reinfected, but those were the 4 endemic countries. So I think that even though we weren't where we wanted to be, I think there was still pretty confident acknowledgement that we'd made tremendous progress and that we were on the right track, and that this was kind of the way forward. I think, and again, I think that at that stage, I think India and Nigeria were the kind of considered to be the key kind of still remaining challenges. And we thought that Afghanistan and Pakistan were headed to eradication within the next year or so, and that would be so that India and Nigeria would be the last kind of holdouts. And I think even though we recognized that that target date hadn't been met, I think there was still I think a real sense of kind of confidence in the program, and that it had made tremendous progress, and that we were pretty close and headed in the right direction.
So where did you head in after December of 2005?
I came back here to Atlanta, and at that time Hamid Jaffrey was the director, and I joined GID again here as the associate director for science. But within just a few months after I was back, I think even 3 or 4 months, Hamid was appointed to go to India to head up NPSP, replacing Jay Winger. And so I was asked to be temporary director, and then eventually was selected to be director of GID, starting out in the middle of 2006, and served there to 2011.
And where did your days intersect with polio?
In GID, certainly, it certainly more than in India. We had a broader portfolio in GID. Certainly, polio was the main focus and the priority for the program, but there was still a very strong effort, particularly for measles, rubella, and looking at bigger immunization systems issues, kind of, and supporting that globally. So we had a separate branch chief for polio, but certainly I was pretty engaged with kind of the polio aspect of kind of looking at what we were trying to do globally for GID with polio.
Anything else to say about that period of time?
I think just a couple of things. One is again to acknowledge the tremendous role that Rotary's played in supporting in advocating for the U.S. government to support CDC's efforts for polio. It would certainly not have happened without Rotary's influence. Not only in India, but certainly even in this country, Rotary has tremendous connections and capacity to advocate for polio, and CDC's role could not continue could not have happened without Rotary. I think secondly, the other thing in GID that one of the things that I tried to push there, and that is get CDC much more engaged with research and in research projects in terms of at the country level, and trying to advocate for that being a kind of a clear role, thinking about at that stage again, thinking that our role in terms of implementing and supporting at the field was going to be evolving in another direction, that we were going to really be reaching eradication very shortly. And so that that would be, we were looking to move more towards looking at broader research areas. And I think, even though it's certainly been strong before, I think trying to strengthen the links with the lab, because the virology lab has always been at a different division. So looking at how, particularly on the research side, working with the lab of doing a lot of research projects that involve that. And kind of related to that is we moved from into the Global Health Center, which was created just about the time I was leaving in 2010, I think. So looking at GID moving again from immunization and virology group to a more of a global focus, and thinking longer term about how GID could fit into global health security and kind of broader global health issues.
Could you say more about that?
Well, I think that certainly GID was initiated, as I mentioned really before, in terms of Bob and Steve, in terms of, again, very heavily focused on polio, and then broadened out to measles and measles rubella. And again, very vertical kind of approach that was centered on those specific diseases. And GID gradually expanded to look at immunization systems, as I mentioned, in terms of workforce development and surveillance in particular. And I think then that also evolved into thinking beyond immunization. And I think it was a little bit of a kicking and screaming, but I think being put in under the global health system made sense in terms of recognizing that what we were doing in the immunization area had a lot in common with all the other programs that CDC was engaged in globally, everything from HIV to malaria to other aspects that looking at the systems development that was required for these initiatives was really kind of linked with what some of the things that we were trying to do. And in some ways, more so than, for example, at NIP or the National Immunization Program at CDC for the U.S. So.
I'm thinking of a second question similar, because that kind of pertains to the impact of polio on CDC, which I think is really interesting. So in parallel, what would you say the impact of polio eradication has been on WHO?
In WHO, they split polio out from EPI, I forget, in the late 90s, or I'm not exactly when it was, but in what was the immunization, IVB, immunization, vaccines, and biologicals, and they split polio into a whole separate division. And that had its pluses and minuses, the whole aspect, again, of, as we've kind of alluded to various times, about vertical versus systematic approaches. But certainly I think that generated a focal point for WHO's kind of real role globally. And that was kind of mirrored in a couple of regions, but not all regions. PAHO never did that. Euro did not. Afro didn't, and then they did, and EMRO did as well. And in Sierra, we never did. We kept polio and immunization all together. So it's been a little bit of a mixed bag in terms of that. But I think that at the global level, they split them out, and that in some ways it really reinforced WHO's leadership role for polio, because there was a very heavy emphasis on it, and the Director General, several Director Generals in succession have clearly supported that as a priority program for the organization. So it's given WHO an identity and a real kind of focus for attracting a lot of kind of really talented people there. But it's also been a little bit of a interplay back and forth between what that's done for IVB and kept them separate, and made it's much more challenging now in terms of, as we're thinking about how to bring those back together as we really need to longer term. How does that going to take place, and what departments are going to have responsibility for what areas. So I think it's been a mixed result, but as I said, maybe it's too early to tell yet because it hasn't really evolved fully yet. So
I'm returning to the timeline. That October 2011. So some of the I'm looking at the pre-interview notes that you made and I made together, and so some of the lessons learned that we talked about were the importance of surveillance and data, non-technical challenges, use of polio for political purposes, and the importance of community, and then the pluses and minuses of partnership in eradication and emergency. So do you want to speak to all of those or any in particular? I want to be respectful of your time, and it's almost I think it's 3:15.
Okay. Yeah, I mean, in some way, I think obviously the importance of surveillance and data, I think is hopefully for coming from the CDC perspective, pretty self-evident. So I don't know how much you need to get into that. I think the only caveat, again, I would say is I think that one of the things we've learned in the polio program is it's also possible to almost have too much data, in that you can certainly it's possible to get evolved to collecting data for data's sake, and recognizing that if you're not really utilizing it for a particular purpose and to drive a decision or to understand a particular situation, that it can take on a life of its own, and that can really be diverting rather than supportive. But I think that's probably enough on that. But I think the other thing, and that is in terms of the partnership piece, and recognizing, again, that we certainly wouldn't have gotten where we are at without the contribution from each of the partners, and the addition with the Gates Foundation in 2005, 6 12 is where they, no, I don't remember exactly when they finally officially joined, but they were obviously
2009.
9. You know better than I.
I believe.
When I remember when they officially joined, because they were engaged before, but then certainly I think each partner has brought individual strengths that have been really instrumental in contributing to where we're at. That being said, it's also meant, obviously, that anytime you're trying to make decisions or kind of come to consensus, it's harder to try and really often get to a appointed conclusion quickly. And sometimes in a emergency, if we're still considering this an emergency, which I think it should be, as we've declared an emergency because of the global implications of it, it can make it really challenging to kind of come to a particular way forward. And I'll just give you an example that we're dealing with right now, and that is in terms of looking at, we have GPEI has become a quite elaborate infrastructure and bureaucracy because it's a complex situation that I think we would not have anticipated in dealing with everything from containment to financial oversight to dealing with other emergencies and how these interact, and as well as the technical aspects of polio and operational implementation of that. And right now we're looking, obviously, we have ongoing wild virus only in Pakistan and Afghanistan. At the same time, we have different groups from everywhere from Seattle to Atlanta, Geneva, New York. Rotary is not as directly engaged in it, but in terms of the day-to-day things, but all these other different organizations want to be engaged, and obviously with good reason about why. And we've talked about, so rather than trying to have, or even looking at it from the technical hubs of Geneva and CDC Atlanta, should we try to have a central hub closer to those countries that can help look at focusing only on those areas and have all the partners just focus and engage there, and could it be in Oman or Dubai or somewhere in that region? And even trying to get to that kind of conclusion is very difficult, given all the different kind of parameters and kind of not only security but geopolitical limitations that some partners have and others don't. And so how do we get to a consensus for that, which may seem a bit tangential, but I think in some ways is very critical to really looking at how do we have a laser focus on managing what's required for the last two countries, so that we don't have this huge bureaucracy spread all over the world when we really need to be engaged very, very focally in terms of how do we stop transmission in these last two countries. So.
When I think about bureaucracy, I think about one of the benefits being the expertise. Mm-hmm. And I'm not even thinking right now about the GPEI, mm-hmm. thinking about any kind of collaborative effort, mm-hmm. really. You benefit from the strengths. Mm-hmm. I also associate collaboration and bureaucracy with longer processes, mm-hmm. And time. Mm-hmm. Do you, in retrospect, see periods of time or moments when things could have moved faster or time could have been saved?
Every time my contract was due, yeah. Yeah, I don't know. Thinking time could have been saved. I mean, I don't remember the exact kind of sequence of events, frankly, when we did the the switch from TOPV to the MOPV 1 and 3 that we did in India, and I'm sure it happened fairly quickly compared to what it could have taken. But as I do recall, it was like that was a really process that had to evolve and took quite a bit of time, even though after we had kind of already decided that in the field area that it was kind of at least effective way to try. And I think we also considered whether we go to BOPV, and so there were some real technical and supply challenges to that in terms of licensing and things that kind of precluded that. So I wish I could remember the specifics on the time, but I think that was an era where we were trying to decide the best way to go, and it always seemed to take an inordinate amount of time to be able to make those things happen, just because of all of the complexities of dealing with new vaccines and licensing and getting sufficient supply and those aspects of it.
Maybe a minus of bureaucracy, I don't know. Is there anything else you'd like to add about partnership, working in partnership?
Only I think just saying, on a personal basis, I've obviously I've worked at CDC. I've been a WHO only employee and consultant for Gates, and actually I've consulted for UNICEF. I've never done a consultancy or worked directly for Rotary, but the other organizations I have, and recognizing, personally that it's really been enlightening, and I've learned and grown in each of those different organizations, and understanding that there's a different kind of culture and atmosphere of each of those that are, I think for the most part, very complementary. So on a personal basis, I think just that aspect of the partnership has been tremendous. But I think also it is an example that of other public health initiatives that can benefit from. I think polio is one of the first, to the extent that it has. Certainly there have been others, but and smallpox was a collaboration to the extent of that, but bringing in and HIV and PEPFAR and others have taken on that model, but a number of other, I think polio was one of the first kind of pioneers of really making it that integrated, and recognizing, I think that this is a real positive model for other public health approaches, even if it's not as a vertical program, but in terms of trying to look at broader public health objectives as well.
So you moved, you left as director of GID in October of 2011, and that's right around the time Dr. Frieden activated the EOC at CDC. Do you remember that time?
That actually happened after I left. So I wasn't involved in that decision. And that was part, though, of it happened shortly after we kind of really got fully, GID got fully moved into the Global Health Center. I was part of that initial move, but then it didn't kind of administratively and everything kind of really solidify till after I was gone. And then I think Dr. Frieden took that initiative, which I think makes a lot of sense at that point, to really highlight the priority of polio as a separate kind of piece to that.
Emergency of international concern, public health, yeah. So then the next date I have marked here is October 2011 to October 2013. You were a program coordinator in Bangkok, Thailand for border and migrant health.
Right, for WHO.
For WHO,
yes. Country office. And actually I had responsibilities for all the communicable disease unit. So it included EPI and malaria and TB were our key and HIV. We had HIV, TB, malaria, which was the Global Fund component, and then we had EPI. And then I also head up a separate unit looking at border and migrant health, which was a critical program for the whole Mekong that WHO was running. Yeah.
And then 2014 to the present?
Yeah, I retired back to again from WHO and moved to California. And so since then, I've been doing various consultancies, some with doing EPI country reviews, and ended up going back to Thailand to do that, which was fun. But also a lot dealing with polio, most directly with WHO. So, and spent some time in some of the various countries in Pakistan for some weeks, and then mostly dealing with working on well, I was involved with the midterm review of GPI, and then the post-certification strategy, which we thought was going to be due any day, but then now this new strategy, which we're looking at from 2019 to 2023.
Which came out in October?
It's still being drafted.
Okay.
So,
is there anything that you can share about that, or your own thoughts about where we're going in the next 5 years, or what you think that might look like?
Yeah, I think it's a real challenge now, and that in some ways I think the program is a victim of its own success. Again, in that polio is no longer a priority for most people, and understandably so in many ways. But thinking about it at all levels, from the community or family level to countries to the global level and global public health programs, it's a very, very small contribution, certainly to global mortality, almost nil, but even global morbidity, there's so few cases. Even the VDPVs, we've got, there's far too many, but in the scheme of things, it's not that big a contributor of mortality or morbidity. So on a global level or even on a family level, unless you happen to be one of the unlucky ones whose child is paralyzed. So I think that our real key challenge now is kind of moving the needle forward and recognizing how do we really get this last transmission reservoirs in these last two countries really under control, and really without and recognizing the jeopardy this has for the years and years of effort and dollars that have been put into it. I think we need to obviously recognize the millions of children that have been protected from paralysis, so that the program has certainly made massive contributions to global public health. But in terms of fully reaching a final eradication goal, which we can justifiably kind of underscore as a major contribution achievement, I think what we're struggling with in these next few years is really looking at how do we make it a priority again at multiple levels, and recognizing I think that we have a lot of technically proven strategies that have worked in 99% of the countries and have reduced it from 350,000 cases now to less than 30 in the last year. So the decline is phenomenal, but that we have to look at ways that, and recognizing that there are a lot of components, some of the geopolitical components of inaccessibility in Afghanistan, for example, that are seemingly outside the real control of GPAI, and recognizing we have to deal with that reality, and how are we going to get around that, and engage the Taliban or others to make that happen, and address the issues that both operational as well as communication issues that we have in Pakistan to really finally stop transmission. So.
Is there anything you'd like to say about transition?
Yeah, I think only that I think we're still at the stage where we need to look at how systems outside of what we've been looking at, specifically polio, how those systems can help to reach final eradication, and then also the component of how the polio infrastructure and knowledge and capacities can help other systems. So I think they need to be seen as mutually beneficial, and how do we get that balance right? I think there's been obviously routine immunization is one of the key areas, but surveillance and other aspects are critical. But knowing that I think there's a much greater appreciation now than we had before, that I think often it was expected that SIAs alone were going to reach eradication, and that routine immunization was over here, and this was kind of just another avenue that needed to be done, but for the longer term. I think there's recognition now that we certainly need both, and that the routine immunization systems, not only in the remaining endemic countries, but certainly in all of the other countries which we need to protect from getting VDPVs, that we have to have strong routine immunization systems, and the lessons and the capacities we have from polio can help to do that. At the same time, polio is dependent on those systems being functional and effective as well, and we can't look at them longer in terms of operating totally independently. And again, this gets back a little bit to what we were talking about with WHO and looking at how do we kind of merge those kind of administrative components back together, but also the mindset of what's required with that. And linking in, again, the aspects of emergency and emergency outbreak response, and recognizing that we have a lot of other things going on now. The Ebola outbreak is a good example in DRC, where obviously polio is it can be a fairly lower priority when you're dealing with something like Ebola, but recognizing that the polio capacities in that area and the staff have a lot of experience in dealing with outbreaks and things that may be useful for Ebola, but also the WHE and platform that have been developed for outbreaks can serve as a real component that could really help with future polio outbreaks. So I think the transition writ large has to be seen as kind of still as a mutual benefit society going forward in terms of both reaching eradication and ensuring that other public health objectives can be met.
And so it's not either a horizontal approach or a vertical approach.
Yeah, I hate to be kind of not trying to be to cut too fine a line on that, but I think that's right, and I think it's a disservice. I don't think it's either side, but I think it's a shortchanging of the capacities of both to try and keep it separate and not to acknowledge that there can be real benefits to mutually working together.
And do you think that will reshape the approach to immunization? I don't know if we're reshaping, but I think that certainly we already know that and India is a great example of where the polio capacities have really already been moved heavily into supporting
routine immunization, and the other public health programs. The SMOs are engaged in everything from Kala Azar to malaria, and it's providing epidemiologic and monitoring support for multiple programs and supporting measles SIAs and others. So I think that that's certainly already evident that that can be done. I think where we need to look more is how do we really bolster infrastructure and EPI capacities in places like in Quetta in Pakistan, where immunization coverage rates are in the teens, just because the facilities don't exist and the capacities aren't there. So we have to look more creatively at how do we utilize the polio components and structures to help do that. I think there's a lot that's already being done with that in terms of using the community-based volunteers to support EPI, but I think we can look at how that can be managed even more effectively and look at how to ensure that the CBVs can play even a bigger role if necessary in the routine immunization.
Do you have any final thoughts on anything that we've talked about today? And would you be open to a second interview at a later time? Perhaps.
Not today, but
Okay,
another
yeah,
time.
Of course.
No, thanks and good luck. I think it's great that you're doing this. As I said, I think the smallpox program, they had produced that big red book at the end, but that, I think it may not have captured all the kind of the nuances and the activities and really the personal vignettes that I think went into it. And hopefully, I think I'm really glad that you're making this effort now.
Yeah, we're all very lucky. Yeah, we're a team of several people. So
Good.
yeah, thank you so much.
Okay, thank you.